Thank you. Hello, everyone. Good afternoon, and it's so great to see all of you. So today we will be dealing a very simple and light topic, but still a very powerful topic, which has to be understood in detail. And this is something that has to be used in every setting, if I say it properly. Without much introduction, I'd like to invite Ms. Smriti Rana for the session. Thank you, Smriti Rana, for joining us, and please take over.
Thank you, and hi everyone. Nice to see everybody again. Cameras on, please. And this is a class on communication, and one of the biggest barriers to communication is that I can't see your faces. So we'll at least for a short while get our cameras on. I'm a little nervous now that Manisha has said this is a light session. I'm going to try and keep it light, but I don't promise that it will be a completely light session. So sorry, Manisha, I'm going to have to disappoint you there. Okay, so today's session is on communication, and it is, of course, the backbone of what we do. What I'm going to attempt to do today is just take you through some of the most basic fundamentals. And yeah, and as we go along, I will stop and pause for interactions. I think you all know how I function by now. So we'll just take moments where we will sit down, reflect on something that we've just talked about together, or something that we have watched together, or something that we reflected on together. So let me start by sharing my screen. Okay. Manisha, is it visible?
Yes, ma'am, it is.
All right. Okay, so we're not just going to talk about communication, we're going to talk about effective communication, and there is a difference between the two. So first off, let's establish that there's communication and there's effective communication. And there are three aspects to effective communication: communicating with patients and their families, communicating with other healthcare providers, and lastly, which we don't think about very often, but raising awareness about a cause is a form of communication as well. And I'm not going to get into that third aspect, the last two aspects today. We have another session on communication coming up next week where we'll be tackling some of them. We'll take a deeper dive into that. But today we're just going to talk about some of the fundamentals of communication. And I would say you could apply this not just to your patients and families, but also in other forms of communication and other interactions that you find yourselves in. So firstly, I'm going to try and share a video. Manisha, I'm going to rely on you as usual to please let me know if the sound is coming through, yeah? Let me just try and see what this is.
All right.
It's not coming through, is it?
Let's say it's Friday.
Audio is there, video is not there.
Okay. Sorry, you all have to really struggle with my that I'm going to just try one last time, okay? And see if it comes. Now?
Video is there. Can you start playing it?
All right.
Quick reactions from everybody. This is a film, so some of it might have been dramatized like that, but just responses, and we're not doing any sort of evaluation. So what were some of the things that came up for all of you? Please feel free to unmute, use the chat. Impersonalization, objectification of the patient, okay. It can be anything. Communication with the patient is important, and it is better to explain to the patient the condition and not use the medical terms. Yes. Did you observe anything about this exchange that really stood out for you? The patient is not at the center of the treatment, mere spectator, the different ways we communicate vis-a-vis patients, doctors. Okay. So in the interest of time, I'm also going to move along. If anything else comes up for you, please continue to put it in the chat box. No privacy for the patient. Yes, Dr. Vinita. Why did we go into that flashback about her as a child? Was that something important? She says that one of those doctors were her students in college. Apart from the doctors in this group, did anybody else understand what was happening with her? And there was one part which stuck out for me, which is, he says, what else is the side effect? What else is the side effect? And they come up with all kinds of things. And then he says, use your eyes. Hair loss. And their response to it is, that doesn't even count. You know, that's supposed to be normal. So I'm just trying to get you to sort of reflect on this, because I'm sure not exactly in this way. Many of us have had similar experiences of different degrees, perhaps, where we have been the object, like you said, and people have, and this happens where a lot, unfortunately, in some of the healthcare settings where you're talked about rather than talked to. And nobody asked her, by the way, what she has felt after taking the medication. Did you notice that? Nobody asked her how she was feeling. In fact, after everything that they discussed, they say, okay, full dose. And you can even see the way the doctors look at each other, because that full dose means something. So anyway, so I'm going to move along now, and you can actually watch the whole film. It's quite brilliant. It's called Wit, and you can find it online, I suppose. Okay, so coming back to what we are doing today. We talked about grand rounds. Now I'm going to just, by the way, this case study is a real case study that it's a case that I'm seeing at the moment. Miss, would any of you like to read this out? Any of you like to just unmute and read this out for me?
Mrs. M has suffered a serious stroke. It has left her in a semi-conscious state. Her chances of recovery are not good, but it is unclear how long she will live. Her husband is her primary caregiver and is confused. They have two daughters. One lives in a different city and travels to her parents occasionally. The other lives abroad. The daughters have a difference of opinion. One wants to focus on comfort care. The other wants to spend money on interventions and more doctors. They cannot agree on how to manage the father or the patient. What are the communication challenges for you as a care provider?
Thank you, Abhijit. So let's hear from all of you. What are some of the challenges in communication specifically that you see coming up for you? Suppose you're the caregiver, you're the doctor, you're the healthcare provider for this case. What are some of the difficulties that are already quite obvious here from the point of view of communication? And remember, this is a communication challenge for you, not the family. The last sentence is, what are the communication challenges for you as a care provider?
Hello, ma'am. This is Srinivas. See, basically, in this case study, if you see, the two daughters they have a difference of opinion regarding the care which is being provided to them. One is focused on comfort care, and other wants to spend money on their interventions. And they are not able to know. But in the first paragraph only, it is said that she is had a severe stroke, and her chance of recovery is unclear actually. So whether the communication which has to be provided to the family members or who is the primary care giver is also very challenging to find out here. And one thing is they are not on one term. One person wants to uh, go in a different line of treatment, the other second daughter would like to go on the other treatment. Like she feels that the current treatment what she is receiving is not adequate, so she wants to go to more doctors and take a specialized treatment. And uh, and the father also, like they are there is a lot of that bond as a family member and staying together united and working towards one goal that is being missing here according to my observation.
Thank you, Srinivas. Anyone else? If you were handed this family to help, what would you be anxious or nervous about addressing with them?
I would like to speak, ma'am.
Please.
Since we see that the primary caregiver is father and two daughters have similar goals, treating the mother well, but their priorities are different. So,
How is it?
shall I continue?
Please go ahead.
Yeah. So both have different priorities, but the goal is similar. They want to make the mother comfortable. So the question here then it comes that they cannot agree on how to manage the father or the patient. Like both have different opinions, but goals are same. So I think as if I am the treating person, I think I'll be more focused on what the primary caregiver has to decide for the patient. And since patient is in a semi-conscious state, patient cannot speak for herself. So we have to think about the primary caregiver. And I think I'll be more focused on the primary caregiver instead of two people who are yet to decide what to do.
Okay, wonderful. Thank you. I see Alice also. Alice, you've unmuted.
Yes. See, I'm going through the same situation now. Actually, the one difference is that I have also two daughters, but they are in the same opinion. That is the comfort care, focus on the comfort care and comfort care for me also, because I am the most sufferer in this scene. We have one male, my husband is in the same situation, and we appointed one male caregiver, but he's refusing it. It doesn't cooperate with him. So that is very important here. The caregiver is more important, as she said.
Thank you, Alice. And
I have got the support of my daughters. That is why I'm managing everything.
Thank you for sharing that with us. We have somebody else who's also sent a direct message saying the challenge would be to find the proper approach to treating the patient and some sort of middle ground, proper ground between the two daughters. Okay, so you can come at this from different directions, right? You can focus on, and the patient is uncommunicative, so you don't know the patient's wishes. She's not being able to respond. And I completely wholeheartedly agree with all of you that the caregivers are important. And it's the father who's the primary caregiver on the ground. The other two are in different cities and one is abroad, right? So the one who's abroad, and I think I mentioned this in my last session also, maybe there's a sense of guilt that is driving this. Like, I just want to get my mother something really expensive. I want to get more doctors. I want to do this, but I'm not here. I just want to do as much as I can. I'm not going to resolve this case, but we're going to go through effective communication and then talk about how maybe you view this case differently towards the end of it. There's a second case study, also a true life case. Would anyone else like to read this out? Any volunteers?
Mr. J has been diagnosed with an aggressive and advanced form of cancer. He retains functionality and is not in pain. His wife was a dentist and is deeply religious. She believes prayer will cure him. Their only daughter has been abroad through the pandemic and is now visiting. She understands that his time is limited and she would like to speak with him about his wishes before she heads back. She doesn't know if she will get the chance again, but her mother doesn't want her to and stands guard over the father. The daughter is distressed that her father knows about his prognosis, but is not being given permission to acknowledge it and get his affairs in order. So the question is, what are the communication challenges for you as a caregiver, care provider?
Slightly different case. So what would you find? So here's a scenario. Yes, the mother has some, she is from the medical field, also very deeply religious, does not want the daughter to have a completely honest conversation with her husband. The daughter only has a little bit of time left before she has to go back abroad, and she wants to have an honest conversation. So not all communication challenges are end of life challenges. It's also a lot of this sorting out, these kind of dynamics. So I'm just going to check the chat box to see if, okay. So any thoughts? Where would you think the challenge really lies? Who are you going to talk to? Who would be your first, where would be your first point of entry with this family?
Mr. J's wife would be entry point, and then a daughter.
Okay. Anyone else?
There's a comment in the chat box. Dissonance from caregiver who feels decision must be hers.
Yeah. I struggle, hence I get to decide. Yeah. True. Okay, so I'm just going to come back to these cases later. This is just to sort of give you two different scenarios that are current. Okay. Now coming to communication itself, the single biggest problem in communication is the illusion that it has taken place. The single biggest problem in communication is the illusion that it has taken place. I think I've told you what I need to tell you. You've understood it completely differently. Is that communicate? I can tell everyone that no, but I explained to the patient and the family exactly what the problem is and how they should go about doing it. But the family has gone and done something completely different. So the single biggest problem in communication is the illusion that it has taken place. And I'm always, if I'm the one communicating, I think I've done a great job of it, okay? But how has it landed with the other person? Now, firstly, let's go back to the fundamentals. This is a class on fundamental communication elements. So why communication? Can you tell me why is communication important in a care provision setting? What does communication serve to do? And just give me any thoughts that arise in your mind. Why communication? Might seem like a basic question, but what serves, what purpose does communication serve?
To express our feelings, the status, what we are actually, and to share our expressions, feeling, to tell what we want, to get what we want. And it is the key of our existence actually.
Okay, to express ourselves and to be heard and understood. Somebody has messaged me saying to bring clarity. Yes, it conveys the exact feeling or message. Thank you, Sunanda. It decreases error, very important. There, now I can see the chat box warming up. Help in treatment planning. Yes, of course. So let's go. What about establishing trust and rapport? You can't really communicate much with, you can't get very far with the patient unless they trust you. Sister Jeanette, you have something to say? Would you like to unmute? Please feel free to unmute. In the meanwhile, better working environment for ventilation of emotions, I suppose. Yeah. Okay, listening and understanding. Okay. From the care provider's point of view, firstly, it helps me establish some sort of trust and rapport if communication is done well. It allows me to elicit the concerns of the patient and the family. Venting and ventilation are different. Rajiv, would you like to elaborate on that?
Ventilation is more about respiration, getting in and air in and out. So venting is more like, getting the emotions out.
Okay, thank you for that. Important nuances in communication. Okay, elicit concerns, helps the patient to make decisions, as Kavya. Okay. Very, very importantly, it allows us to provide information. If we don't communicate with our patients and their families, how do they get the information that they need, right? Plan treatment, some of you have already mentioned that. Discuss prognosis. Where is this illness going? What is the expected outcome from these treatments? Establish goals of care. We talked about this, remember, in the basics, in laying the foundation for good practice. You have to establish the goals of care. What are your goals of care going to be? And how will they change over a period of time? Suppose somebody goes for chemotherapy or gets a surgery or has some sort of intervention. And then how have they responded to it? Now, what is the next step? So establishing goals of care. And if you've read this book by Atul Gawande called Being Mortal, you'll find that, he actually demonstrates it quite beautifully in the book, where at one point in the book, he has this conversation with his father, and he came upon this insight where he asks his father, what would you like to be able to do through your illness? And the father says, I would like to be able to, I forget what the father's answer is, but based on that, they decide the goals of care and the plan of care. Okay, so establishing goals of care, that requires very good communication, actually. Resolving confusion and conflict, oftentimes between family members, sometimes between the family members and yourself and the healthcare team. Okay, so that's where communication becomes important, and very important to provide emotional support to the family and also to your team members. So don't forget that even your team members might need to work through some of the more difficult cases together with you. So these are just some of the building blocks of communication. I'm not saying that this is the final list. You can keep adding to it depending on your own work setting and what you find communication is really important for. Now, very important, who communicates, what to communicate, and how to communicate. We talked about this also, that the main caregiver may not be the decision maker. So who are you talking to in the family? And is it the right person that you're talking to about a particular issue? If I'm going to be talking about, feeding schedules, medication schedules, skin care, oral care, all of those things, then yes, I should talk to the primary caregiver. If I'm talking about the cost of an intervention that they should consider, is it that person that I should be talking about if they're not controlling the finances? No, I should be talking to the person who actually controls the money, right? And therefore makes the decisions. What are we going to communicate with the family? We talk about the impact of treatment, we talk about concerns, we talk about challenges, there are all kinds of things we talk about. And like I said, we even talk about goals of care, eliciting other sorts of concerns and so on. And finally, how to communicate. There are verbal ways to communicate, there are non-verbal ways to communicate. Just one moment, sorry, just give me one. Okay, sorry about that. And also how to communicate. When what has worked for me when I help a family navigate a particular, illness trajectory, I usually encourage the family to write down questions, concerns in advance before they meet the healthcare team, and to be as specific as possible. So usually what I would say to them is, before you go to talk to your doctor, there are three kinds of things that your questions that you write down. One is about the actual care of the patient. What do I need to do in order to look after this person physically and make them comfortable, and all of those different things. Secondly, what are the resources and things I'm going to need in order to make this intervention possible? Not just in terms of money, but in terms of, say, equipment, airbed, medication, the cost of medication over a long period of time, etc., etc. And lastly is about emotional concerns or about psychosocial concerns. It's going to be very difficult for me to keep my mother in my home for more than 2 months because I'm expecting a baby, and and then my husband's family is also coming over, like those kind of things. But is there a way that we can coordinate this care, or for some time we can get her respite care? Whatever, there are various different questions that people can ask, but usually just the very act of sitting and writing that down clarifies a lot of the thought process for people. And plus, in that time, that limited time they might have with the senior physician or whatever, it also ensures that they don't forget some important questions, because sometimes the conversation gets away from them. So these are just some basic things. These are some of the things that we need to remember. Who are we talking to? What are we talking to them about? And how can we help them communicate better with us? Okay. Now, I think we've talked about this before, but Manisha, I'm so sorry. I can't recall if this was part of the assessment presentation, but we did levels of clinical decision making, where one is just information, where as a care provider, I just provide information. This is what you have, this is what you need to do. Paternalistic is when I give information along with recommendations, like this is what you have, this is what you need to do. Out of all these things, this is what I recommend, because in my experience, this is what has worked. And finally is shared decision making, which is, this is the information, here are my recommendations. What is it that you value? What are your preferences? What can you afford? Are you okay with these with these interventions? So is the difference between the three clear? And what are we striving for in palliative care, and actually in healthcare? What we should be striving for is the last one, shared decision making, where I give the right information, I give my recommendations based on evidence and my own experience and research. And thirdly, I have to take into consideration the values and preferences of the person that I am caring for. Okay, that last bit is not easy, and many of us don't know how to do that. Okay. So the other consideration is there are three phases, right? There's the diagnosis, there's the treatment, and the prognosis. And what are we aiming for with effective communication? Is that at the time of diagnosis, has everybody understood the diagnosis? Has everybody understood the diagnosis in the way it's in a realistic manner? What are the potential trajectories that the illness will take? What are the different ways in which the illness can go? And is there a role for palliative care in it? And this comes back to the basic point that palliative care is not just end-of-life care for terminally ill cancer patients. It is something that can be brought in as supportive care for all serious health-related suffering. So if somebody has just been diagnosed with an illness, I sometimes get called in by families where they say, hey, listen, mama just got this diagnosis. They say it's early stages, but I just want to talk to you. Is it too early to talk to you right now? And I say, no, maybe not. Let's have a consultation with the doctor. And at the moment, is your mother in pain? Is she in distress? What is her mobility status, etc., etc. Until nothing serious is flagged, we're just on standby. But the minute there is some sort of indication that a palliative care team needs to come in, we mobilize that support. And this is the time when this thing happens, doctor shopping. Do you know what doctor shopping is and why people do it? What is doctor shopping?
Meeting many doctors.
Okay, yeah, going from doctor to doctor. And why do families do that?
For getting better treatment, ma'am.
Better treatment? Any other reason? Lack of trust? multiple doctors to confirm the diagnosis or get better care, monitoring, desperation, easy course of treatment. Yeah. Also, don't forget pressure from the families. Huh? Hey, you must meet my uncle's friend who was in college with him because he went to this excellent doctor and he'll introduce you. So, okay, we'll do it. There's a lot of unsolicited advice that also goes on. Okay, so that in diagnosis, there are all this. Now, if I'm not able to establish that rapport or that sense of confidence and competence, I'm very likely to have a patient that go doctor shopping. It might be too many opinions as well, but the point is that if I'm not confident in what my healthcare team has said, if my doctor doesn't talk to me properly, if my healthcare team doesn't really have time to talk to me properly, I'm going to go to somebody who actually pays more attention to me as well. Okay, so compliance is also determined by your communication skills. So coming back to the screen. So once the diagnosis is agreed upon and the person goes into treatment, the importance of communication is to understand the effectiveness of the treatment, its implications. Now, if I have to explain to a family that, hey, if you do this intervention, then these are the side effects, this is what might happen, this is what you might expect, this is how long the treatment will go, this is how expensive it might get for you, and assessing the treatment impact on the disease, on the patient, and the family. This is really important. How will this treatment modify the disease? What does that mean, though? What are the side effects of this treatment? And chances are, yes, this might shrink the tumors, or it might, reduce your pain or whatever else, but something else might also happen. What is the impact of this treatment on the patient and the family? Now, I'm going to stop sharing my screen for a minute because I think this is a very critical point that doesn't get discussed very often. We end up discussing the intervention and its impact on the disease. Do we talk about the impact of that intervention on the patient and the family? And in what ways? Your tumor might be shrinking, but you're going to be nauseated for 6 days a week. The disease is responding really well to this treatment, but it's going to cost you something like 4 lakh rupees a month. So this is what I mean by impact of the treatment on the disease, on the patient and the family. I think all of you had, you've met Dr. Aju Matthew in the last session, right? Yeah. I once learned this phrase. I don't know if he used it. Sorry, I missed his class, but the wallet biopsy. Did he talk to you about the wallet biopsy? And this is the first time I heard it from him. A wallet biopsy is to see, okay, you know what? I can tell you that this is really got great results. Great evidence for this particular kind of drug to work. But like I said, it's going to cost you something like 3 lakh rupees a month. You're going to need 3 cycles of it. Do you have the ability to go through these cycles at that price and still be okay as a family? What is it going to cost your family in order to do this? Now, public health says 3 times national GDP is my optimal spending for reasonable benefit. Okay, I'm going to need to unpack that a little bit. So this is what we mean by a wallet biopsy. Am I inflicting more suffering on this family by not thinking this through with them? The end. Is this family, is going to shrink, but the family is going to be so impoverished that somebody is going to have to give up something really major in the family, like selling the house. So that is what I mean by discussing the impact of the treatment on the disease, on the family and the patient. And this is what in many ways is called a wallet biopsy. And I think this is quite critical. It's not something just a doctor can do. It is also something that all of us can get involved with. Affordability in the long run is pretty much what I was just talking about. And finally, prognosis, goals of care. What is acceptable to the patient? What is acceptable to the caregiver? What is the caregiver capable of doing for the patient? When to stop treatment? Very, very difficult conversation. Very difficult, one of the most difficult conversations to have. And finally, the location of care. What are the options? What is the kind of support that would be needed when the patient's disease is so advanced? And do they have access to palliative care in those settings? Now, a lot of people at this point want to go home, but they need to know what all they need at home in order to care for this person. That is also a very important part of communication, because you have to work through it with them. You have to get them to think certain questions. You've got to get them to participate in the problem solving. And that is why this is also very important. Now, we talked about the trajectory. So there's diagnosis, treatment, and prognosis. And then there is who decides. Okay. There are three sections here. The patient decides who decides for them. And the third is the family decides. There's no discussion, or no one decides. These are three separate things. Huh? Either the family decides as a whole without any discussion, or no one person decides. They're like, no, we'll just leave it to the doctor. No one decides. Doctor, you only say what we have to do, we will do that. There is no decision from our part, except we will follow whatever you say blindly. Now, the patient can decide what they want for themselves in terms of treatment, in terms of interventions, etc., provided they have all the information, one, and two, the decision-making capacity. They have to have the information and they have to have decision-making capacity. I'll talk about that to you in a minute. The patient will decide who decides for them. I don't want to decide my son is going to make all decisions for me. My daughter is going to make all decisions for me. And the conversation has to be had in advance, preferably when the person is healthy. Like if I'm healthy, I need to say, when I'm sick, my brother will make decisions for me, or my husband will make decisions for me, because I trust that they have my best interests at heart. Ideally, we should have those conversations when we're healthy. That hardly ever happens. Roop Gursahani is going to talk to you about advanced care planning, and this is going to come up again there. And if not healthy, at least when they're lucid and they can think straight. The third is patient's wishes and preferences are not considered. It's a very emotionally charged situation, and decisions are made during a crisis. And usually at this point, the families either just decide together, or nobody decides at all, and they ask the healthcare team to start deciding things for them, and they will just follow through. So I said the patient makes decisions when they have the information and decision-making capacity. And what is decision-making capacity? And this is something that the physicians here will be able to sort of corroborate. A person has decision-making capacity. She can, one, describe a current situation or an illness articulately enough, describe consequences of accepting or declining a given route of treatment. So if I tell you that this is what chemo is going to do, these are some of the side effects, these are some of the outcomes. This is what surgery is going to feel like, and this is what your recovery period is going to be like. We hope that at the end of that, you will be able to do X, Y, Z. Okay, I'll have that surgery. Okay. And the third is the person should be able to demonstrate judgment. They should be able to make choices between two interventions, and they should be able to explain to you the rationale as to why they chose it. So these three things actually is together tell you what decision-making capacity of a person is. Okay. And if the patient can speak coherently, their choices and their decisions come first. If a patient can speak coherently and they decide that this is what I want, then the healthcare team has no choice but to honor that, ideally. But my question now is, again, let's go into a controversial space. What I've just pointed out to you is the ideal. What do you really see happening around you in the situations that you've witnessed this? What has your experience been? Any comments? Patients is never heard. Sorry, Manju?
Most of the time, family members decide. We don't listen to the parents.
Yeah. So what I'm showing you here is a very Western model, where autonomy of the individual and stuff is given a lot of importance. Culturally, in India, it's the family that makes the decisions. Okay, so let's also remember that what is considered best practice or ideal, it also is very culture specific and context specific. So while, you know, communication textbooks will tell you that this is how it has to be, we know that the reality is like this, and then we need to facilitate conversations within the family. So even if it means me telling the patient, help us decide who to talk to. Who in your family do you want us to talk to? And maybe we're talking to 3-4 people, but who do you want us to talk to some more? Okay, so maybe that's also something that we can do. Okay, now coming into the actual, so we talked about the trajectory, we talked about the people involved. Now we're talking about where all of these conversations take place. The conversation can take place in a hospital setting when there is acute care needed, when the person needs medical support and interventions and medicines that can only be given in the hospital, when there are procedural interventions like, say, you know, an IV line or a catheter change or some other kind of thing that cannot be done at home. Close monitoring of symptoms is needed because maybe, you know, some of their parameters are off, and maybe it could be the blood pressure, maybe it could be the sodium level, whatever else, and that cannot be monitored at home. It has to be done here. And of course, affordability. You know, I need my mother to be admitted in the hospital also for a few days because she will get better care there. I can afford it, and this allows me to also do some of the other tasks that are absolutely important at this point. The second kind of care setting is in a hospice, in a nursing home, in a long-term facility for care. And this is when extended care is required. Again, affordability is a big issue, and the family's capacity to provide that kind of care is also considered. The third kind of setting is, of course, at home, where you have access to support, and family dynamics basically determine what that care will look like. Now, the conversations that you as a healthcare provider have with the family, with the patient, will happen in one of these three settings. And the context will decide the content of your communication. Okay, what is the context? Why are they there? And therefore, what should you be talking about? And sometimes in the hospital, they might be talking to you about how do I transition the person either to a long-term facility or to home, because keeping the person in the hospital is just not economically possible for me right now. Okay, or the fact that we are now foregoing futile treatments. We basically have to take care of my loved one at home till the time that he or she passes on. So all of these conversations happen in these different settings. Now, why is it difficult to have these conversations, and why is communication so difficult or often ineffective? And there are several reasons for it. And I'm going to ask you to please feel free with your sharing in the chat box. And if you have anything that you'd like to particularly add or reflect on, just put your hand up and then we will stop and listen to you as well. Firstly, there are many barriers, and the barriers are of different kinds. There's professional barriers. Okay, barriers that I as a professional put in the way of good communication. What are some of the barriers that I bring to an interaction? I'm just going to start you off. Let me see if any of you have anything to add to this. I'm so scared of what this patient is going to say if I tell him XYZ. What if the person gets angry?
So are we talking about barriers to communication?
Yes, we are.
Okay. It could be, I mean, because every individual is unique and everybody has a different idea, perspective, understanding of various aspects based on their whole, worldview or perspective, what they have experienced so far in life. The way they look at things are different. Whether it is the patient or the caregiver could look at same thing and have different opinions. So and coming to a consensus between patient and the caregiver, or between caregivers, family members, that is where the barriers could come, to make each other understand and coming to the same page and agreeing to, even though there are many disagreements or different opinions, coming to an agreement on what is best for the patient. So I mean, based on, because each individual is different, there could be barriers to communication based on just on that. Again, there are a lot of things like education, qualification, the information that they have, all could play a part in it.
You've got most of it covered. Yeah. And thank you for that. Thank you for those inputs. So like I said, and you've covered a few of these across different categories. So if we talk about the professional category, me as a care provider, I'm afraid of this person's reaction. And this is usually something that happens very early in your career as well, because you haven't yet had the experience to try it out on a real person, when you have to go and say, I'm so sorry, but this treatment didn't quite work the way we hoped it would. And sometimes as a junior, you might get yelled at, or you might, the person's emotion might come out on you. So you're scared of that. And that might be a barrier to communication as a professional. The other thing could be just not knowing what to say. I don't yet have the vocabulary. And if you see, this is where the medical jargon comes in, because sometimes it's easier to use those big words rather than to talk about the implication of what you're saying. Right. So this intervention didn't work because, the tumor has metastasized to several sites, and we tried to do this procedure that nobody really understands. But it seems like you've said a lot and you've told them the truth. And before they actually understand what has happened, you're out of there. You've done your job. The greatest illusion is that communication has taken place. Okay. Not enough time. The fact that all of us are under such high pressure, those of you who are working in hospitals and things like that, I mean, especially if you think back to COVID times and how things were, do you really have the time to have long conversations with your patients and their families and understand where they're coming from? What are your concerns? How can I talk you through this whole experience? No, there is no time. And this is actually one of the most cited reasons for why communication doesn't take place properly. Shared distress. Again, COVID was a major example of this. It was so distressing for the healthcare workers as well at the time. And we don't have the time to go into this, but there is something called secondary trauma that a lot of healthcare providers also go through. If you're going to be seeing suffering and pain and distress and all of that all the time, and then when you have particularly difficult cases, we're human. We also feel the distress, and sometimes that itself becomes a barrier to communication. And fear of blame. Lately, you might have noticed how much antagonism and, there's a lot of violence against doctors. There's a lot of violence against healthcare providers. We've seen that happen in so many situations where suddenly it'll be on the news that some doctor got beaten up, some nurse was abused, somebody or the other went after this healthcare team. And now that has created a culture of fear. Because if it's not that I didn't do my best, it's just that the person beyond helping at this point. But then next thing you know, half the village or half the neighborhood has come and they're banging on your door. And I know a lot of doctors who've gone through this in the recent past. And so, yes, that becomes a barrier to communication as well. And poor role modeling. Many of us healthcare providers did not have proper role models. Some of us, of course, had excellent role models, but then for a lot of people, they have had seniors and role models who've been very gruff, who've not demonstrated empathy when it comes to patients and families, who belong to that kind of school of thought where, the doctor has that God complex, or the healthcare provider, there is a dynamic in terms of power structure. And so, whatever the healthcare provider and the professional say, that's the last word, that's the end of that. So we are not taught communication skills at medical school. Yes, in fact, like we were talking about this, attitude, ethics, and communication was introduced in medical school in 2019. So we're not taught how to do it. So poor role modeling is a big professional barrier. Then there is barriers of attitude, and this is not just for professionals, it's just all around. I don't need to communicate. I'm an excellent surgeon. Why do I need to sit and go through communication classes? My work speaks for itself. I communicate through my expertise and my competence. I don't need to sit down and learn how to go for a communications class. My juniors will do the communication for me. My social worker will go and communicate. I'm doing all the tough stuff, you know. I don't need to go and sit with the family and figure out, you know, why the brother didn't come and why the sister is crying. That's not my job. I don't need to learn how to communicate. I don't have time for communication because I'm so busy saving lives. And you know, I'm the one who's actually doing all the surgeries. I'm doing the one. I'm seeing like 50 patients a day, and I'm helping in that way. So I don't have time to sit and, you know, spend half an hour with all my patients. That's not my job, and I don't have time for it. I don't think it's important. Have you come across? And it's a fact. There are people who actually don't think it is important. As long as we fix the disease, we target the disease, we treat the disease, and we cure it. As long as we do that, why do we need to sing and dance? You know, why should we make a song and dance about it? Environment is a big one, and we know this, those of us who have worked in government settings as well as some of the other resource poor settings maybe might be quite familiar, where there's lack of privacy because of crowding. And, you know, you can't really sit down and have a very effective interaction with somebody in a busy OPD when there's constant noise, there's constant people walking around, somebody or the other is coming to get some file signed by you or some notes to be added, or, you know, check something else. So lack of privacy is it's a big one. Physical barriers. So I worked in an OPD where there is a table the size of a horse in that room. And if I even need to talk to the patient or the family, this huge thing is just there between us. And I can't even tell you how big that table is. And we couldn't get rid of it, because in order to get rid of that table, you have to go through the entire hospital hierarchy to get some, you know, paper signed by some supervisor somewhere. And so it's never going to happen. But this also comes as a major physical barrier between the family that I want to talk to and myself. And that in and of itself psychologically impacts the communication process. Ideally, you have two chairs facing each other at an angle, you know, you're able to pick up the non-verbal cues and things like that. So when you have big physical barriers, it actually hampers communication in a big way. And you may not really feel that's the case, but for the person on the receiving end of that communication, it is something that definitely gets in the way of proper communication. Also physical barriers, like the fact that my Zoom might just act up anytime. You know, my connectivity might act up anytime now. And I think, you know, someone said that modern day Zoom meet like olden days, like seances, like where you call spirits using that Ouija board, because you're like, are you there? Can you hear me? Is someone here? You know, but it seems like that to me as well now, because I find this to be a physical barrier, honestly speaking. And even more so when cameras are not on. So just to let you know, that's a huge physical barrier for me as far as thank you for turning cameras on. Okay. Noise distraction, not just in terms of crowd and, you know, people shouting and stuff. Your phone, in my case, my dog's barking randomly at something, it can be a big distraction, and then that derails the conversation. And sometimes the barriers come from the patients and the families themselves, because there's a fear of questioning professionals. There's a certain section of us who don't like to question the doctor, and who don't think we should be questioning the healthcare provider. In fact, when you question it, somebody in your family will nudge you in the ribs and say, what are you saying? Don't be disrespectful. And so why would also somebody be fearful of questioning a professional? Because they've probably had a bad experience in the past of being yelled at. Sorry, Sajan, were you going to say something?
I was going to say that because it has become a norm that you are not supposed to question the doctor here, right? In Indian culture, that's how it is.
Yeah.
So it has become a norm, and then it is taken as a ego problem, with the physician. So do you know more than me kind of thing is a straightforward question. They answer back.
Absolutely. Absolutely. And it's really sad because by the end of it, they've not understood anything. They've not understood the prognosis. They have not gotten the information they need. And they're afraid of asking any further questions. Fear of death and dying. I don't want to go there, because what if the news is bad, and so bad that this is what the implication is? Protection of other people. Now, what do I mean by this? You're going to hear more about this idea of collusion, where two people team up to keep information from somebody else. But protection of others. What are some of the examples of me not communicating because I want to protect somebody in a healthcare setting? Can you think of any examples?
A patient who is critical in critical condition may not be in ICU exactly, but in critical condition who is not ready to take some mental bad news of something happening outside. So, for example, if one of the closer relatives had an accident or something else happened to them, and it is not told to the patient because they are not ready to take that impact. Those kind.
Absolutely. And it can also go in the family where you don't tell some other family members that this person's illness is getting worse. So protection also is a barrier, and sometimes it's one of the biggest barriers that we encounter that we have to get over.
Smriti, can I share experience? Yeah. So recently I met a person in a workshop, like it was, the workshop was on cancer, stuffs in one of the states. So like he said that I purposely did not tell my father that you're suffering from cancer. So like people from Pelham, India, and we were there, we questioned him that why you didn't, it's actually, we say that you should tell him. So he was like, he said that, नहीं मैं खुश हूँ because I don't have the guts to tell him because मुझे लग रहा है कि if I don't say, he will live longer. I don't want to break that news, He said that he didn't agree till the last. We couldn't convince him that you should have told him, That's what I wanted to share. Thank you.
Thank you, Sunanda. And that is such a common scenario. It's such a common scenario, and it's and the thing is, finally, at the end of it, everybody suffers. Everyone suffers from that. Thank you for sharing that. And sorry, I'd like to spend more time listening to all of you and also just unpacking what you're saying. Also a little mindful of the time. One of the barriers are social barriers. And what do I mean by social barriers? We as a society are a death-denying society. There was a time when all of us had some sort of familiarity. I'm talking about culturally, where people had roles to play in the rituals. And probably, when it was not, I came across a beautiful word recently that somebody shared with me. It's called technocratic. So before medicine became so technocratic, and there was still humanness in our interactions and things. So, loss and grief and all were accepted as something that every human being goes through. But now, no, if somebody is going through grief, we have to fix it. If there's a loss, we need to make up for it. And we are, as a society, more and more death denying. And if you look at all the rhetoric, okay, how do we extend life? What is that elixir of youth? People going and freezing their cells and, to be revived later when the technology is available for it, like talking about immortality and things like that. So as a result, these kind of conversations become very, very difficult. Have you ever sat down and tried to have a conversation about death and dying, or even like advanced illness with somebody in your circle of friends or your family? What is the most likely response you're going to get if you imagine if you plonk down at dinner? I know there are some of you are very evolved, but what is going to be the majority response if you sit down at a dinner table and say, hey guys, I want to talk about death today at the dinner table? What's going to be the response at home? Are all your family members going to say, yeah, that's a great topic, let's talk about that? Huh? No.
We can talk about life after death.
Yeah, you can talk about life after death, but can you talk about death itself? No, you can't. And if you even talk about illness and stuff, it's almost like, it's abshagun. We don't talk about it's inauspicious. Let's not talk about it, because if you talk about it, then you're going to make it happen, and we don't want to do that. So let's not have that conversation at all. So we're going to talk about that more in. I'm not muted. Can you hear me, all of you?
Yes, yes, good, good, good. Maybe they can check their connectivity.
Okay, Rajiv, I'm going to come back to your question a little bit later. Okay, just give me 1 second. Just one. Sorry about that. Okay. Okay, so we are a death denying society by and large. This is not a comfortable topic, and therefore we will not talk about it. And expectation of medical miracles is a big social barrier to good communication, because this is unrealistic hope in action. And you will find that, we don't want to have the conversation about palliation, about comfort care, about all of those things, because suddenly someone will come and say, hey, go here, meet this guy. He's got some radical new treatment, give it a go, because I know it's worked for 5 people. You'll try it. Chances are a lot of people will try it. I remember having this conversation when I was very, very young. I was in a hospice. I was a junior, and I watched this man who was in a very advanced stage, and it took the counselors and the team at least 5 or 6 conversations before they got him to accept that his illness was now terminal. And finally, this man seemed to be accepting it and, coming to some idea of peace around it. And the next thing I know, he's being whisked out of there. And everyone was a little bit upset. And I found out that some relative had come to visit him and told him about a drug trial that was signing up patients for, to try out a new experimental treatment. And he signed up for it. And I also remember him coming back to the hospice about a month later, with not even a month later, maybe 2-3 weeks later, with what looked like 3rd-degree burns all over his body because he had reacted badly to that drug. And now we had to start the whole conversation again. But this time he was in so much pain that he couldn't participate in the conversation. That's the expectation of a medical miracle. And very often you find this, it's not just allopathic. You might have some, traditional treatment being offered somewhere else. It could be a person. Go and meet this Guruji, or go and meet. And yes, there's a time and place. I'm not berating anybody's faith here, but it's also the timing of it sometimes, which makes it very poignant and tragic when something cannot be reversed. So those kind of things also become barriers, because after that happens, if I sit and try and have a conversation about, any other thing, it's not going to take place. So that becomes a barrier to communication. And cultural barriers, of course, some of the most common misunderstandings result from negative stereotyping. It could be about gender, it could be about age, it could be all kinds of things. How many of you have had the experience that they want to just talk to a man and prefer not to talk to a woman? Alice, I can see you nodding vigorously in agreement.
Yes, yes. I had one experience the same. I am the caregiver, but the doctor is asking somebody who is man, who has to talk. I have to talk to him. Then I said, no, I am the caregiver and I'm his wife. You have to talk to me. And he's reluctant to talk to me.
There are cultural barriers. And in fact, this could also happen in the reverse, where they don't want to talk to a female doctor. I can see Dr. Usha nodding now. where where they assume that the woman is the nurse, and they would prefer to talk to a male doctor or something of the sort. So gender stereotyping, it can be age. I remember as a 19-year-old caregiver, nobody wanted to talk to me. They wanted to talk to anybody else in my family except a teenager. And they didn't want to hear from me at all. So many things get in the way. And so culturally, there are lots of biases that are barriers to good communication. And it hampers the whole process drastically. The other thing is that medicine itself is a subculture. What do I mean by that? Those of us in healthcare have a whole other secret language. It's not even that secret, really. It's just that we have a way of communicating with one another where some things, some of us develop a sense of humor around something dark, because that's the only way we can cope with it. Or some of us develop this other language of, say, just, our approach to certain kinds of patients. Who is a difficult patient? Who is a difficult patient? Actually, I should ask, amongst those of you who are in healthcare, who do you consider to be a difficult patient? Any responses? Who is a difficult patient or a difficult family member?
Who wants the progress to be made within like a short span of time, which is not achievable. They come with a grade 4 bed sore and they say that you are only a doctor, you should save us, or something, like a lot of expectations on that, and asking every day, nothing is happening, what you people are doing, it's been 10 weeks, 2 days or something like that, and they keep on asking. So those are like very much challenging to handle.
Yeah, I can understand that. Short-tempered, questioning, stubborn, one who knows it all, those who've gone in. How about the guy who goes and reads Google every day and comes back and tells you what your job is? Yeah, but I saw on Google, why are you not prescribing that medicine? So your 10 years of medical training is nothing, please. I mean, I should just go read Wikipedia. So this is, but those of us who are in healthcare, patients who want to be saved when they are at end of life. So those of us who are in healthcare, we recognize this kind of person a mile away. And what happens? Hey, no, yeah, today I'm really not in the mood to have this conversation with this kind of person who's come to me with Dr. Google. Please, you go talk. Please, I can't have one more conversation like that today. So there's this whole subculture also amongst us where we decide, okay, today's your turn. You go and handle that person. And so it is, there is a subculture, there is that. And those of you who are on the front lines together, you know that there's this code of communication that we all share that maybe outsiders don't have. Okay, literacy. Okay, so this is a question I'm going to ask you, and we don't, I'd really like to know. Literacy is often considered a major barrier. Literacy, the ability to read and write. I'm going to ask you today, do you think literacy is a barrier to effective communication? Anyone? Is literacy, the ability to read and write, a barrier? Abhijit?
No, not really. We should be able to come down to the level of the patient and explain in simplistic terms.
Okay. I see Purnima has said a capital no. Anybody else?
Yeah, sometimes sometimes I consider it to be a barrier in such a way that when we are taking some consents or something, they don't know what is written there, and we don't tell them that yeah, this just you sign it, this is what we are administering the drug. But he is not well literated so that he can go through each and every line and procedure whatever we are doing. But when we are taking the consent or something, we don't tell each and every word which is printed there. So in those terms, I feel it could be a barrier in communicating what the healthcare professionals are doing to them.
Okay. So I see that also as a logistical issue also, because maybe I don't have someone in my team who can read this out to someone who doesn't read or write themselves. But I wonder if I had such a person who could actually read it out to them. So it's also a human resource issue. But literacy in and of itself, should it be a barrier? No, like Abhijit has also said, we have to, tailor our communication in a way that someone who can't even read can still understand us. What happens with illiterate patients when you want to give them medicine? And you want to say, this is for your morning, this is your evening dose. How would you do it? How do you
Usually we
color code
make,
it? Color code it?
Anat?
we make it like a sun in the morning, and night we make the moon.
Yep. I walked in a beautiful palliative care unit in Pokhara in Nepal. And it's an outpatient department that sees cancer patients, it sees people with dementia, it sees people with, rehabilitation needs and so on. Every door in that clinic is a different color. So that even children or people with dementia don't, they don't get disoriented. So it's color coded to that extent. And it was amazing that actually this was so well thought out. It's not that it's only for the kids, it's not only for this. So they also had stuff that was textured in a particular way. And I found that quite amazing as well. So there are different ways to overcome these kind of barriers. Humans, also navigate the world through their senses, and we can use those kind of cues to help them understand what needs to be understood. And of course, when it comes to consent forms and things like that, having somebody explain it to them makes a big difference. Okay. Sorry, we have 10 minutes. Let me just see how much more we can cover. All right. So let's remember one thing. Illiterate does not mean unintelligent. Very important. Illiterate does not mean unintelligent. And that it would do us all some good to bear that in mind always. And if we look at even our grandparents' generations and further back, where maybe in some cases the women were not sent to school and things. I mean, but they ran households. They ran the whole show. So illiterate does not mean unintelligent. Okay. Communication skills can be taught. Do you agree with this statement, or you think that unless you're a born communicator, there's no other way? Can communication be taught?
Absolutely.
You can just use the action buttons so that we can move along from this. Just use the thumbs up button. Is there a thumbs down button? I don't know. Okay, yes, it can be taught. I can see a lot of things down here. Great, because that's why we're having this session, right? Otherwise, we shouldn't even be having a communications class. So yes, it can be taught. And I strongly believe that this is something that we should be learning right through our lives. Communication is one thing. There is no end point. There is no end point to constantly improving your communication skills. And it could be written skills, it could be spoken skills, it could be so many other things. And I think communication is an incredible art as well as an incredible science. Okay, and effective communication, it is not what you say, but how you say it that has the most impact. Now, this is a statement that has been in our communication training circles for a very long time. I personally disagree with this statement because it's not entirely true. What you say is as important as how you say it. Okay, so I don't agree with the statement. So when we share this PowerPoint slide, Senior, please remind me to mark that, because the last thing I'm saying is that this is true. And very often people say effective communication is 7% words, 38% tone, 55% body language. The man who did this study has gone blue in the face trying to explain that he meant it for emotional communication and not for communication in general. But unfortunately, people have only taken this and said, so it doesn't matter, your words don't matter, as long as your body language is great and your tone is great, you're fine. No, that's only for emotional communication. I can't be talking rubbish if I'm trying to like, you know, impart life-saving facts. As long as I do it nicely, I can just say whatever I want. I can recite a nursery rhyme. No, it's not true. You have to be accurate, as accurate, or not accurate, but you should strive for accuracy in the words that you choose, as well as in the way you convey your words. That's what I personally think. And I'm open to debate about that. And we have just a few minutes. So this is one thing I'm just gonna, I'll go through this section with you, and then we'll stop for the day and then continue in the next communications class. There is something that we do very often unconsciously when we are not comfortable in a situation and we don't want to get into a communication interaction. And these are called distancing behaviors. Sometimes we do it consciously, but very often it happens unconsciously. What are some of these distancing behaviors? Now, I want you to think about a time. And for those of you who are healthcare workers, I'm sure you've also had experience with other healthcare workers. So I want you to describe a time you did not feel comfortable or heard or understood by a healthcare provider, okay? A time that you did not feel comfortable or heard or understood by a healthcare provider. I want you to take a minute to just go back to that experience. And I don't want you, I'm going to try and ask you to not go to the emotional part of it. I want you to go to the other sensory parts, okay? What was it that the person said or did or didn't do or didn't say that made you feel uncomfortable or not understood in that situation? I want you to describe the behavior of the person that made you feel like, okay, I was not understood. So take a minute to think about this, to recall this memory, and then feel free to share. Anyone want to go?
The tone of the voice is like rude or agitated, like he's in a hurry or troubled, and you feel like you just have to get out of here. This person has no time for me. That way.
Okay. Anyone else? Unless all of you have had great experiences, in which case I really want to see your healthcare teams.
I have actually lots of them. I don't want to take time to mention that.
No, go for it. Any other people can just say agree and disagree also if you've had the same experience.
One instance was my dad was going through dialysis, for at least a couple of years. In between, there was an instance where they didn't look at, they didn't probably notice it properly, and then there was a leakage of blood, and then the whole blood, whole body, shirt, everything like got soaked in blood. And then when I came to, I was not here at that time, and then when I came to know and I questioned them, they said, "Oh no, don't worry, it's actually little blood, it happens all the time." They put it so casually and callously that I couldn't even bear. If I was there, probably I would have reacted very badly, but that is the way they took. So that is one example, and there are lots of them. So somewhere it didn't go well in that instance.
I'm sorry you had that experience. And yes, the act of minimizing somebody's experience or diminishing it and saying it's not as bad. So it's almost like saying you're overreacting. So to invalidate somebody's emotions by your words and by your actions also. So I see that we are at the end of the hour, but I'm just going to take you through one last slide just to corroborate or, just to go over some of these experiences of what it is that might have made you uncomfortable in a particular situation. And if this is true for you, then please You can signal it using some sort of emoji, reaction, hand raise, whatever. Eye contact. How was the eye contact in these situations where you were made to feel uncomfortable or you felt uncomfortable? Poor? Poor eye contact, would you say is accurate? Okay, fine. Facial expressions. Unwelcome, unfriendly. Yeah. Tone of voice, like you said. Indifferent or impatient. Either I don't care or, God, you're really irritating me with your questions. Body position. Not posture, position. Okay. Paternalistic. Now I'm going to tell you what that is in the next session. How we place ourselves in relation to the other person. If somebody is sitting and I'm standing. If somebody is standing and I'm sitting like this and not letting them sit down. So body position, where am I physically placing myself when I'm talking to somebody, when I'm communicating with them? Body posture, that's a different thing. Negative body posture. Arms crossed, turned away, 1 foot out the door, just very close like this, like not even looking at you, those kind of things. Their attention. Did you have their complete attention at that time? Sometimes they're distracted by something else. They're looking at their phone, they're looking at their watch. Oh my God, I'm such an important person that, people are waiting for me outside. So I better make this really quick and make sure you feel that my attention is not fully here. And finally, the focus, which is slightly different from attention. The focus is on the physical, not on the emotional, not on the spiritual, not on your feelings. I will only focus on the disease. That's it. I'm not going to talk to you about anything else. So I'm going to stop here. And we have another communications class happening next Wednesday. And we will continue this. We will continue talking about this. And in the next section, we're actually going to go deeper into communicating bad news, talking about some very difficult situations and how you as providers. So far, we've just sort of described the different variations and the scenes. From the next session, we're going to actually talk about the interventions. What can you do? We've talked about the don'ts. We're going to talk about the do's. We're going to talk about how to have some of those conversations, what you should be doing in terms of your environment for prepping for those conversations, and how to see those difficult conversations through. This is by no means a comprehensive communications module, but hopefully it'll get you interested enough to also then go and do your own research and read up on it more. So thank you very much. And I'm going to stop for now. And Manisha, back to you.
Thank you so much, Smriti ma'am, for the wonderful session.
Thank you.
Yeah, and thank you all of you for being patient and listening. And I hope all of you had a really good time of learning. Thank you so much once again. Bye-bye.